welcome to the first Scientific Preemie Chat. Before we begin, I would like to acknowledge that Indigenous peoples are the traditional guardians of this land we call Canada, in which we gather here today for this discussion. The Canadian Premature Babies Foundation is situated on the traditional territories of the Anishinaabe, the Haudenosaunee Confederacy, and the Wendat peoples. We also acknowledge the land covered by Treaty 13 is held by the Mississaugas of the Credit First Nation. We also recognize the contributions and enduring presence of all First Nation, Métis, and Inuit peoples in Ontario and the rest of Canada. We are grateful to work on this land. I'm Fabiana Bacchini. I'm the Executive Director of the Canadian Premature Babies Foundation, or CPBF, and mother of a surviving twin born at 26 weeks. CPBF is a parent-led charitable organization that helps families in and after the NICU stay through education, support, and advocacy. If you are a family or a healthcare provider, please check our website, canadianpreemies.org. There you'll find resources and a community of people who want to see our little babes thrive. And it's been almost 4 years since we launched the Preemie Chats, our weekly education sessions for healthcare providers and parents to talk about what matters to you, to explore new ideas, and to learn together. This is our first Scientific Preemie Chat. The format will be a little bit different as we are bringing experts with different care practices to discuss a topic that hasn't reached an agreement among clinicians, scientists, and the community in general around the world. For this first session, we will continue our conversation on the global theme of this year's World Prematurity Day: small actions, big impact, immediate skin to skin for every baby everywhere. And the question today for our experts is, in infants born less than 26 weeks, do you practice early skin to skin care within the first 72 hours? The World Health Organization recommends immediate skin-to-skin care for survival of small and preterm babies. But do NICU really follow these guidelines for the smallest and most vulnerable babies, especially those born under 26 weeks gestation? Is this a lack of evidence on benefit, lack of evidence on safety, lack of training and support, or just personal bias? Today, we are presenting this session in collaboration with the Canadian Preterm Birth Network, the Canadian Neonatal Network, EPIC, the Evidence-Based Practice for Improving Quality, the Canadian Neonatal Follow-Up Network, Family Integrated Care, Canadian Association of Neonatal Nurses, EFCNI, the European Foundation for the Care of Newborn Infants, and GLANS, the Global Alliance for Newborn Care. We have here live an audience from 53 different countries around the world, and we want to hear from you. Let us know where you're joining us from. Please send your questions, insights, and you can add them on comments, and we'll try to address them during this session. We really want to hear from you. What are you doing in your units around the world? So now I'm very honored to introduce our moderators for this session. So the first one is joining us live from Vancouver, Dr. Souvik Mitra. He actually is the one who prompted this session to exist. He asked this question on Twitter a few months ago and created this great discussion with scientists from around the world. And that's why we are here today, to make this discussion even broader. Dr. Mitra is a staff neonatologist at the BC Women's Hospital and an associate professor of pediatrics at the University of British Columbia in Vancouver. He serves as an associate editor for the Cochrane Neonatal Group and co-chairs the academic committee of the Neonatal Hemodynamic Research Center and the Evidence-Based Practice for Improving Quality, EPIC, the hemodynamic group of the Canadian Neonatal Network. Dr. Mitra, thank you so much for joining us here today and to start this incredible conversation that we are about to have.
Thanks, Fabiana, for having me and putting this together. This is incredible. So, just to give you a background on how this all came about. So, as neonatologists, our goal is to provide evidence-based care that leads to the best outcomes. So in general, for preterm babies, I've always strongly advocated for and supported skin-to-skin care without hesitation. But when it comes to the smallest babies in our unit, I've questioned myself while supporting this practice. Am I doing the right thing? I know parents are loving every moment of this cuddle, but am I increasing the risk of brain bleeds by moving the baby around? That will be devastating for the parents. So, as you said, that a few weeks back when I posed this question to our colleagues on social media, we got hundreds of responses. Interestingly, a two-third to one-third split against early skin to skin care in the smallest babies, which is the very reason why we are here today. And again, thank you, Fabiana, for bringing me and our esteemed guests and moderators, which I'll let you introduce, and then we can dive right into the discussion.
That's wonderful. Thank you for being here. So our next moderator is joining us live from Munich, Germany. Silke Mother, who many of you know, she's the chairwoman of the executive board and co-founder of EFCNI, the European Foundation for the Care of Newborn Infants. Silke is also a mother of surviving twin born at 25 weeks, who is now 26 years old. Silke is an incredible advocate and inspires all to continue doing this work as parent organizations from around the world. She's also the co-editor of the EFCNI benchmarking report, Too Little, Too Late, Why Europe Should Do More for Preterm Infants, and technical editor of the Born Too Soon Global Action Report on Preterm Birth. Besides this, Silke is an author and editor of many other publications on topics related to maternal and newborn health. Silke, thank you so much for being here with us today. I am very excited to have you and Souvik moderating this great discussion.
Yeah, first of all, thank you, Fabiana, for having me and also starting this discussion, what comes up last year when WHO has published these recommendations that babies born preterm should have an immediate kangaroo care situation, skin-to-skin care situation, and really from the moment of birth. But this brings at the end the question up, how early can you really provide this? And when it comes to the parent's perspective, of course, as Souvik said, of course, we want to cuddle our baby and we want to hold our baby, but it's also important to really have it safe. And what we definitely not want is to risk any kind of infections, brain bleeding, or any kind of complication, because when you put the baby out or immediately after birth means in the delivery room, having already a very early skin-to-skin situation. On the other side, we also know that many years we have the discussion of parents bring in the infections. Kangaroo mother care is not evidence-based medicine. What in the meanwhile WHO has shown, and we also know from hospitals, and this will have today a controversial discussion. I'm really looking forward to it, because we have hospitals, they are practicing it. And is it at the end an excuse to not having in the end a skin-to-skin situation in the delivery room? Is it, I would say, just an excuse we have not enough staff? Or is it an excuse not to have the parents or the father in the delivery room? Is it an excuse to just say, okay, that's a lot of work, a lot of questions, we have to be super safe and super careful when we are doing or practicing it? Or is it really a discussion of better not to do, to provide at the end, or to prevent in the end the brain bleeding? And this is what my perspective was. Of course, I had nothing like this at all. We had 6 weeks after Lucas was born. And but it's also important to discuss the comfortable situation, not only for the baby and the family, but also for the nurses and the doctors, because when they feel not comfortable, then of course it's a challenge. But it's also for us important, if that is the case, do you need more training, education? Do you need more information how to do it? And then we have to discuss about increasing the numbers of nurses and doctors and improving the education and training for doctors and nurses to provide this care, because WHO is not recommending it just by a joke. It is really an evidence-based practice, and it is of course also proven because other hospitals are doing it. And this is in the end our position as patients, safety always first, but not as an excuse. And so this is why it's also my pleasure introducing the first discutant here in our session today. It's Dr. Elizabeth Rogers. She is professor of pediatrics at the University of California, San Francisco. She practices neonatology in the intensive care nursery, and she is also the director of the Roots program, the Grow Small Baby Unit, and the research director of the ICN follow-up program of the University of California in San Francisco. And of course, her big interest is, of course, preterm birth, but there is, of course, a lot more what she is interesting. And it's, of course, family-centered care, it's palliative care, but it's also, in the end, the outcome, the neurodevelopment of the children. So how can we ensure that the babies really has the best outcome? And therefore, I'm happy that you are here, Elizabeth, and hearing your opinion about the discussion we have today on the topic. Thank you for having you today here.
Thank you so much. No, I'm thrilled to be here. When Souvik started his tweet, I was quick to jump in because it's a topic that I feel very passionately about and have led implementation science and quality improvement efforts across California, where I live, but also through the Vermont Oxford Network and our current collaborative on All Care's brain care, because I firmly believe that skin-to-skin therapy or skin-to-skin care is neuroprotective at its core. And so I really started in this because as a junior trainee and early faculty, I heard from families, they would recall the first time they ever held their infant skin to skin. And often it was, 30 days or 15 days, far too long. And yet the impact of that first encounter where they were really feeling reunited with their infant was so healing. And that made me delve into the evidence. And so we'll talk about it, but it certainly is something that I believe to be one of the most evidence-based practices that we can offer in neonatology. But as Souvik and as we'll talk about, it may be a knowledge that we have in a different way, even if we don't have randomized control trials. So I think it's very evidence-based. I think we've shown through quality improvement efforts that it's safe. But there's a lot to talk about in terms of reducing the variation and making sure that each local context is ready to implement early skin-to-skin.
Thanks a lot, Elizabeth. So, it's an absolute pleasure to have experts from two very high volume NICUs who care for a lot of extremely preterm babies with great success, yet have such different approaches to skin care, which leads me to introducing our final discussant, Dr. Patrick McNamara, who is a professor of pediatrics and internal medicine at the University of Iowa. We all know Patrick as a great advocate for hemodynamic management for the smallest and sickest babies. He's been doing that very successfully for the smallest babies at the University of Iowa with one of the best outcomes, I would say, across the world. And that is why we were so interested to know from him how he approaches this issue of skin-to-skin care early on, because hemodynamic care, skin-to-skin care, they're all related and it's all geared towards precision management of these very vulnerable and fragile babies. So, Patrick, welcome. It is a setting which is very different to what you are used to with talking about hemodynamics, but we'd love to hear from you and your perspectives on this issue.
Thank you, Souvik. Yeah, I feel a bit of a fraud here, kind of the least knowledgeable person here in the group, but that's okay. I am always happy to learn. The one thing I am not is I am not on Twitter. I try to stay away from that because it'll just cause me too much stress. Evangelical comments at times that happen on that, but certainly I think the reason I'm here is, we are a center that does not practice early skin to skin, yet have got kind of pretty good outcomes. This is not my decision. as to why we don't have that, but this is the reality we live in, and certainly kind of I'd be happy to share any thoughts and perspectives, in terms of how that decision was made, and also we'll probably reflect on where the program may be going down the road as well. So,
yeah, great. So I guess we'll jump right in because we only have an hour, and I'm pretty sure we have so many interesting topics to discuss. So the way I was thinking was kind of pose a couple of scenarios to both of you, and try and understand what your practices are usually in your own units. So the first, simple, straightforward, you have say a 24 and 1 week baby, 12 hours old, received surfactant early on, but since then has been extubated, very stable on CPAP of 5, room air, everything is stable, lines are in good position. Parents would love to have a bit of skin to skin. Maybe I'll start with Patrick. What is the approach in your center?
Okay, so I'm laughing, Souvik, because you said the baby's on CPAP, and the baby won't be on CPAP in our center. the first issue here, and that's another traditional Iowan philosophy, and I think that the one thing that I hope we will get to here is that when one is looking at practices, they're looking at evidence. The ability to integrate, extrapolate from center to center may not always be so easy. Okay, so the first comment I would make is the Iowan approach is very much a culture and a philosophy, and there are certain elements of that philosophy that they may not all be perfect, and not everyone may agree with them, but within the framework of the patients we take care of, there are certain things that are unique. So the first unique thing, you've already touched on it, is in Iowa, we don't extubate tiny babies, okay? And that's very much based on the belief that, the potential risk of kind of post-extubation collapse or re-intubation instability is too much of a risk the smaller you get. So kind of our belief here is that first intention high-frequency ventilation is a more optimal way to manage the lungs of these extremely tiny babies. Okay, so the first thing is the baby's not going to be it's not going to get extubated. I won't say that there are not exceptions to the rule. There have been. Some neonatologists have kind of extubated tiny babies, and that has been successful. And certainly, I'm not necessarily saying that I don't believe that we should not be extubating tiny babies at all. But this is our practice. The outcomes speak for themselves. Here, we have guidelines around skin-to-skin contact, 14 days. This is the Iowan approach, okay? And within that, there are kind of, traffic lights in terms of even if you get to 14 days based on X, Y, and Z, there are certain situations where even by a 14-day-old extremely preterm baby that's on a lot of respiratory support, maybe nitric oxide, whatever, arterial lines may not actually the parents may not get the opportunity to have skin-to-skin contact. Okay, so it's not happening. Okay, I'm not saying whether that's right or wrong, but it just does not happen. Obviously, the challenge is when you have a program that has got, the highest rates of survival in the smallest babies in the country, across the range of 21 to 26 weeks gestation. It's very hard then to, convince people who've built this program that maybe we can get the same benefit even with skin to skin. And we'll come back to that, later on, So, and I think the decision that was made was very much based on a direct interpretation of trial evidence and extrapolating that down, or perhaps focusing on the lack of trial evidence in tiny babies, again, we can talk more about that, and a little bit. I'm sure we'll have some great comments there. So
perfect.
Is that what you wanted me to say, Souvik? Is that
absolutely? Thank you, Patrick, for kind of giving us an insight into your unit, to kind of understand what is going on in terms of practice.
And just one last comment, maybe. I think the culture and the philosophy is based on the belief that you're dealing with extreme organ vulnerability, extreme physiologic sensitivity, and it's not that we kind of don't put babies through aggressive things. We do lots of echoes, lots of things on these tiny babies, but those things make sense to people because they focus in on data, physiology, optimization of things, trying to normalize the physiologic environment, and by doing that you can reduce bad outcomes.
Yes, no, absolutely. Thanks, Patrick. Silke, do you have any questions for Patrick regarding this practice around this particular scenario that we discussed before we move on to Elizabeth to understand what happens in their unit?
Yes, one question. I was a little bit surprised that it's 14 days. It's really a long time. And what I have not got in the very beginning is it is all the babies under 26 weeks need to wait 14 days, or
under 27 weeks. If you're above
under 27 weeks.
Under 27 weeks. You're above 27 weeks, it's 7 days.
Okay. Okay. Yeah, because because you said before you are comparing with other hospitals in the US, do you also compare your data with other hospitals across the world? I'm just linking into hospitals like we compare ourselves always in Europe to Sweden, especially to Karolinska. And they, as you know for sure, they're starting skin to skin really from the moment of birth, and also for tiny babies, and also are practicing it. And as you said, it is of course a risk on the one hand with having this good data. On the other side, we are looking always to Sweden and seeing, wow, what they are doing. And so we have, I would say, in Western European countries, not really 14 days. It depends. It's not the day what makes the difference, or 7 days when they order. It's really how the baby is. So I know that it's hard to change at the end when this is the fact, this is the standard, this is the guideline, that's the unit guideline. But do you compare yourself also to other hospitals across the world who are practicing this already?
So great question. So number one, obviously most of our benchmark data is through the Vermont Oxford network, which is like 750 hospitals, some of whom are outside the United States, some Canadian centers, even some non-North American centers in that. We are not part of a network that our data is being benchmarked through different countries. However, we have set up a registry for infants born at the limits of viability, 22 weeks in particular, with very select sites to actually look at, there are 4 or 5 centers in the world that have the best outcomes at 22 weeks gestation. Obviously, some of them kind of in Germany, in Sweden, in Japan, to actually try to pool the data together. But again, that's only specific for the infants that are born at 22 and 23 weeks gestation. I think there's a gap scientifically from looking at more broadly high-performing preterm centers and actually looking at strengths and weaknesses. And the one thing I would share with you is that kind of at a very, very superficial level, if you look at 22 weeks gestation, for example, survival rate in Iowa, Japan, in Cologne, and in Uppsala is almost the same, yet the practices are vastly different and sometimes polar opposite. So that's important for us to recognize that, that I don't think we can be evangelical about any one thing in any one center. And that's where it goes back to my opening comment is, in building your program, obviously the most important thing when it comes to the care of preterm babies is a philosophy or of a culture that you want to do your best, and that sadly is not always the case in every NICU. There are some individuals that, again, this is a strong word, may actively discriminate against extremely preterm babies. That does exist. And we got to prevent that. And certainly, our goal in Iowa is to try to be the best we can. Okay. And obviously, the other thing that's important, and I don't know, we will get to this in this discussion today, but, what is our goal? And our goal is not just survival. Our goal is
exactly
lifelong health into adulthood, so.
Yeah. Perfect. Yeah. Thanks, Patrick. So I'll move on to Elizabeth and kind of play the same scenario. And I want to learn from you what would happen in your unit. And could you just kind of walk us through and describe how would you do it, what you do?
Yeah. So much to say. I'll say it's hard. And for the incredible difference that we have in our practices in Iowa and San Francisco, there are a lot of similarities that Patrick and I hold in terms of really acknowledging and understanding that what your culture is and having everyone brought into your culture is so important for the best outcomes. So what I'll say is that that baby would definitely be on CPAP in our unit. And when we started a major project looking at our preterm outcomes in 2014, 2015, at the time that Iowa was putting out some great data and was sort of challenging everyone's perspectives about how to support our smallest of infants, we at UCSF took an internal, view and brought together a huge group of folks to really look at our practices and look at the evidence. And it was as part of that consensus process where we really doubled down on our skin-to-skin practices and believed that the very stability physiologically that we were looking for could be gained with skin-to-skin therapy as well as not. So we really adopted this philosophy of we never wanted to say, we don't do that here. We wanted to ask, how could we do that here? So that if someone says, why don't you do this? Well, we don't do it. That was never going to be our response. It was always going to be one of curiosity. How could we do that? So in our unit, we first started by looking at the barriers to early skin-to-skin. Some of them exist in our policies without us even realizing it, and they're not evidence-based. So having a UAC, having a UVC, being on a jet ventilator, a variety of different barriers that were put in place, but not with thought or based in evidence. So we first started by revising all of our policies to really allow for this. So in our unit, we would have already hopefully spoken with these parents prior to birth, where we would have talked about the importance of early skin-to-skin. It's part of our counseling when we have a risk, an antepartum risk for preterm birth. And then afterwards, we would give surfactant, hopefully either by non-invasive or invasive means, and whether the baby's ventilated or not, we would work as quickly as we could to have her parents at the bedside and talk through what it means to transfer a baby to their parent's chest. And with a team of folks, and I acknowledge that it is difficult work because it does take a lot of people to be done safely. But we have to acknowledge that just because it's difficult, if it really contributes to the baby's outcome, then it's something that we should do. So our aim and our goal is for all infants born less than 28 weeks to be on their parent's chest within the first 72 hours. And we found that when we first adopted this in 2016, that we did have, so a ways to go. We were doing pretty well already, but we were able to achieve 100% of our infants born less than 28 weeks getting some skin-to-skin therapy in those first 72 hours. But again, very much a multidisciplinary effort in order to really address the fears of some parents. I think Silke mentioned that parents don't want to do anything that's unsafe. And we absolutely agree that that's and we leave it to the discretion of the entire medical team to decide if an infant just may not be ready. But we have very few barriers that would lead us to that decision, but there are some. So what we do is we have a simulation, a doll that we can practice, so the parent can practice a standing transfer. We have a checklist that parents go through where it really talks about our expectations for duration, how they should prepare, how they should be ready to spend a significant amount of time. So we walk them through all of that so that they feel prepared, and we're not throwing them into a situation that doesn't feel right. Now, it doesn't mean that they're not still anxious, because of course there is some anxiety around that very first hold. But we then looked at all of our, of course, balancing measures, very, very concretely, severe interventricular hemorrhage and any unintended extubation, and found that those two, potential consequences did not increase as we were able to increase our early skin to skin. Now, I do want to acknowledge that during COVID, our rates went down, and I think parental presence in the nursery during the height of the COVID pandemic was we did a real disservice to families and babies at that time. And so now we're working through our multiple QI collaboratives to get our statistics back up to that 100%. But certainly that's our goal. And the vast majority of our infants are absolutely held within the first week.
Wonderful. So I already see some comments on the fact that 100% skin to skin in the first 72 hours. That's wonderful. Unfortunately, not all babies are on CPAP of 5 room air. So let's kind of talk about another scenario. You have a 23-weeker born to a mother with prolonged rupture of membranes, intubated, requires high FiO2, is hypotensive, gets an echocardiogram early on, and based on that is started on a medication to improve the cardiac function, also gets started on inhaled nitric oxide gas. The oxygen requirement slowly comes down to about 40-50%, but anytime the nurse goes in to do their routine cares, the oxygen requirement goes up. Parents are anxious, they would want to hold the baby. What would be your approach, Elizabeth, in that baby? And then I'll move on to Patrick.
Yeah. So certainly for us, nothing about the story as you've told it would be a strict barrier to us where we would say no possibility of skin-to-skin therapy for that infant that day. But we do include it as an important discussion on rounds. And so we want to make sure that the baby's nurse, the respiratory therapist, the family, and the medical team are all on the same page regarding the potential benefits of the therapy and the potential risks. I think certainly what we know from the evidence is that for older infants, you have a physiologic stability that you gain by being on the chest. From a respiratory perspective, certainly we see hemodynamic stability be optimized when prone on a chest. And so to us, sometimes we will acknowledge that it is the transfer that tends to be a bit more stressful, but that when you settle into the therapeutic situation, that most of our parameters improve, everything looks better, and so you've gained something from that. And so that's the discussion we have. Do we think that the transfer is worth the benefit that we expect to achieve? And in this case, I would say we certainly use shared decision making, but it would be our recommendation to provide skin-to-skin therapy to that infant.
Yeah, great. So before I move on to Patrick, I have a question from the audience, which kind of aligns with the discussion that we are having. And just to give a background, so I completely agree that when we try and put the evidence in the context of this scenario, let's just go back to the WHO trial, which demonstrated that yes, early skin to skin in the very low birth weight infants reduces mortality, which is probably the most important outcome. When I dive into the details of that trial, the mean gestation age of inclusion was 32 weeks. The question is, was any of these vulnerable infants at all included in those trials, which leads us to a very interesting discussion on applicability of evidence to individual patients, especially the patient population that I'm talking about. So on that note, the question to Patrick from one of the audience members is that everything done to microprems carries a risk. What are the reasons that the physiologic data informing your current practice supersedes other statistical data? Can they be combined? As you have noted, survival alone can't be the only thing we highlight without considering how we can enhance that survival and include other evidence-based practices to have a holistic and healthier outcome during and post NICU. I think, Patrick, you're getting the gist of the question.
Yeah. Like I think, again, I was not here at the time that the Iowa guidelines were established. Our former medical director, who gave his life to the building of the program, had strong opinions on this. And and again, I go, my personal practice or my interpretation of neonatology is that people make decisions for two reasons: fear or science. Okay, and I think this is very much rooted in fear. Now, in saying that, that should not stop us embracing science. And the same fear existed when I came from SickKids to Iowa in 2018 and said, these babies, their clinical picture does not always tell us the truth as to what may be going on subclinically from a physiologic perspective. And if we were to further optimize the care in a place that already has really high survival rates, can we identify better ways to prevent organs suffering the consequences of low blood flow? Okay, which was the introduction of hemodynamic screening. This is an echocardiogram. This is not nothing. This is an intervention that involved handling these tiny babies. And, there was a lot of pushback as to, we can't touch these babies. Something terrible is going to happen. Okay. This fatalistic type of thinking, which I think probably, was the same type of thinking around skin to skin, that these patients are too vulnerable. And you're right, Souvik, like if you be a scientific purist and you look at the literature, we don't have a randomized trial. But for the same perspective, we don't have a randomized trial for any babies at 22 and 23 weeks for most of our interventions. Like, the data does not exist. We don't have normative data. We don't have trial data for much of what we do. And that's, again, it's another important consideration. This is something that seems to make sense. This is something that should be helpful. However, the devil may be in the detail. And if I look at the question, okay, obviously, I think what Souvik is touching on here, we just published a Sentinel paper in the Blue Journal showing that, not only has survival improved at Iowa, but IVH rates have, bad brain bleeding has fallen by 50% and NEC is almost zero. Okay, and this is in a population of infants, a lot of tiny babies, like 48% of our babies under 27 weeks gestation are between 21 to 23 weeks gestation. So that certainly tells me that you can take a program with good outcomes, you can do something that may appear to be radically different, make a change, even without it being a randomized trial, and actually demonstrate a benefit. And I don't disagree with the question. I actually think that there may be symbiosis here. And I think, the devil is in the detail. Not every baby is the same. The other question, again, here is, and this is just for being purely provocative, when you don't have skin developed, okay, when you go down to 21 weeks or 22 weeks, and it is not normal skin, I don't know that we necessarily know anything in those type of patients. We have a baby that's 240 grams in the NICU at the moment. Okay, that baby was very small, very fragile. is that the same or is it not? You know, and again, I don't know the answer to that question, but again, it's another important consideration that developmentally, you know, and certainly from listening to, you know, one of the things that we do here is we don't put babies in incubators, okay, which is another radical Iowism. They're not in incubators, they're in overbeds. And the rationale for that is better because the skin will keratinize quicker. So theoretically, for those most vulnerable patients in our center, we should be able to do skin to skin earlier with less risk because of enhanced keratinization, you know. So I said, these are things for the future.
And I just want to jump in and say, I agree. I think, you know, we tend to group babies together, and certainly less than 26 weeks is a huge, you know, wide range of both sort of physiologic needs. And I loved what one commenter said earlier, which was, you know, these babies aren't sick, they're preterm. You know, they're immature, their physiology needs maturation. And I think that's a really important way to look at it. But I acknowledge that, for example, our center certainly does not take care of the same volume at all of the 21, 22 that Iowa does. And so I think we have to use common sense. You know, where does common sense meet evidence? What are we even able to learn through our traditional modes of knowledge acquisition? But certainly for the vast majority of skin-to-skin therapy, in most instances, I do think we're beyond randomized control trials, because we will not have equipoise in many centers to do that kind of a study. So that's when I think we do need to utilize these great, you know, implementation science networks that we have to look at outcomes, to look at variation across centers. Again, to ask how could we do this and learn from each other.
But what I really think is difficult when we in the end have the discussion about you, Patrick, are only providing skin to skin after the 14 days and others are not. It's not so easy to have at the end really a good randomized controlled trial, and also to really, because when we talk about the very tiny babies, that's a very small group of patients all over the world. As Patrick said before, we have just two of hospitals across the world who are really treating 22, 21 weeker and have even results that they survive. And then at the end, really making a trial where you can have then proper data to really show the evidence on the one hand. And my question would be also to Patrick, because there is a big, as you said before, a big difference between 21, 22, 23 weekers, but there is a big difference to the one who have 26 plus 5 or whatever. And this is in many hospitals and high income countries, standard of care to have really in the first, I would say 5-6 days, maybe not in 72 hours, but in the first week of life, really a skin to skin contact. And what for me is really a challenge to understand. I understand you have a unit protocol, but having at the end 14 days, and then when you are born 27 plus 1, then you have only 7 days. That is not evidence-based also, to be very provocative. And it's not really understandable for a patient. When I just be a next corner, a hospital, then I have the opportunity, and there is not a reason between 7 days, 14 days. And how do you argue about this? I understand the protocol, but it is not evidence-based.
Yeah, well, I think that, again, you know, not my protocol. I
yes, I know.
I have 14 days, but I can tell you that the person here would say we don't have justification in someone at 23 weeks or 24 weeks. That's what they would say. We don't have trial data to show safety. Okay, that's, again, I'm not saying that's the right thing, but that's basically what people, you know, would say. And again, I fully agree with Elizabeth. I don't think the answer to this is in a randomized trial. Okay, just like, you know, here, if you were to come to Iowa today and say to our bedside nurse or some of my faculty colleagues, let's randomize our preterm babies to echo versus not. Now, people would say, are you insane? Like, we have the lowest rates of neck anywhere. Okay, our IVH rates have fallen. You know, our babies are doing better. Why would you now want to randomize them? That doesn't make sense. Plus, as well, you know, and again, I'm trying to not steer too much into randomized trial territory, but we have to be very thoughtful that oftentimes in many of our trials in neonatology, the babies that are randomized for certain treatments may not necessarily be the patients that we're worried about. The actual applicability of evidence sometimes goes back to the detail. I think the PDA trials, again, I'll try not to get into hemodynamics, but they're the perfect example of, perhaps we're just not randomizing the right type of patients. So I don't think we should be doing a randomized trial of skin to skin in babies under 26 weeks gestation. We should be doing exactly what Elizabeth says, taking programs, implementing it, looking at the impact of that, and I think that's the better way to develop science here from this, which is a natural thing that does make sense. But again, the only question I have personally, and from my own personal perspective, is once you get to the point of where you have major concerns about skin integrity, what happens then? Like that's the only, when we've seen some babies, that are 300 grams and they're at 21 weeks and their skin just looks completely gelatinous. Is that the same? Do we have to have a different approach for those patients? And again, it's for a lot of this we just don't know, rather than we actually do know. So.
And we do the WHO, the randomized trial that was done, and Souvik, I agree, the average gestational age was older than what we're discussing today. But, instead of an increased risk of sepsis, they saw decreased incidence of suspected sepsis in the IKMC group, or the immediate kangaroo mother care group. So, there's some thought, but I absolutely agree. And what I also think about with Patrick is, our approaches, it's not, or, it's not either or, it's yes and so we can provide hemodynamically precise care and provide what we know to be physiologically supportive, looking at the different biomarkers of stress for the infant and for the parent, mental health. I mean, there are all the great comments in the chat about all of this, but I think it's a yes and so I don't think any of us know the potential that we have and that our infants have, and it's by constantly sort of pushing the envelope that we will learn. So that's, I think it's likely a combination of our approaches, because when we started our neuroprotective care approach and culture in our small baby program in San Francisco, it was initially for IVH reduction. And we felt that skin-to-skin therapy in the first 72 hours was absolutely consistent with that. So while we achieved our great rates, in that period, we also had 0 cases of severe IVH. So, so again, now if we only had our hemodynamics program, what could we see? So
I think I always have an expression. And this is one I use here in Iowa a lot, because, coming in from the outside to a place that was very, the culture was very entrenched, and this is who we are, this is what we do. But the mantra that I certainly go by in my practice is, if you don't progress, you regress. Okay, it goes to professional sports. Teams have to evolve, they have to get better. And certainly, I know this, we're having a provocative discussion here, but we are actively looking at our guidelines, okay? And I don't want anyone to think that Iowa is this bastion against skin to skin in any way, shape, or form. You can't argue that the outcomes are what the outcomes are, and the system has matured and developed to a state of high level of excellence. But that doesn't mean that you can't make it even better, and it doesn't mean that trying to integrate this into this very well organized system may have another layer of additional benefit from that perspective. So,
yeah. So one question that often comes up is around the barriers, and Elizabeth, you talked about IVH a few times, so I think it's a right opportunity to bring this up. One of the big barriers that we hear is midline head positioning, neutral head positioning, and that coming in the way of taking the baby out and doing anything. There are 3 randomized trials, just around 200 odd infants, has shown no effect on severe IVH. The statements, the position statements, recommendations, they recommend midline head positioning, but you go into the detail on the level of evidence, the strength of recommendation is very low. The question is, has this recommendation caused irreversible harm by leading healthcare professionals to believe that there is strong evidence to carry on with this practice at the expense of other potentially beneficial practices like skin-to-skin care?
Well, I don't believe anything is irreversible. I believe we can always reverse, but as Patrick mentions, culture change, that's another area that I'm very interested in and study, is very challenging. And I also acknowledge that this has been, I have talked about the importance of early skin to skin for years in these large, fora. And still every time someone says, but what about midline head positioning? So I agree. The evidence is weak. And yet I can see how people say, this idea of common sense meets evidence. Yet common sense, if you have a 90-degree torque in a very, extremely preterm infant, do you get some occlusion to venous return? Does that contribute to some stasis that, your cerebral perfusion gets impacted? Is there some plausibility to that? Maybe. But I think the evidence has not shown that to be true. And yet we have another practice that it is inhibiting, that the WHO and Cochrane and everyone acknowledge has strong evidence for likely benefit. And so we cannot have something with weak evidence supplant something that has strong evidence and get in the way. But commonsensically, if you're in charge of positioning for that infant, because the infant's in a warmer in Iowa or an isolate in San Francisco, and you can keep them fairly midline at low effort, it makes sense, right? Common sense, you might do that, but you don't let it get in the way of providing a therapy that has greater benefit. So anyway, I'll keep saying it, which is basically what Souvik just asked, but I do think that recommendation has been a barrier.
Yeah, which is kind of a nice segue into I want to know from Patrick your thought, because your approach is more physiology based, trying to marry physiology with whatever evidence is there, and sometimes there might be a tendency of us getting too overconfident in our understanding of physiology, and that coming in the way of other evidence-based practices. I mean, midline head positioning is one thing. Is just one example. So your thoughts on how do you balance that? We know that there is little evidence in 20 to 23 weekers, and therefore our only approach is understanding the physiology and making the best rational decisions. But there's also a risk to that. And this is my wearing my EBM hat here, from a purely evidence-based medicine perspective. I see that there is also a risk. So how do you balance that risk?
Yeah, no, I don't disagree, Souvik. Like, as I said, if you look, at what we have at 21, 22, 23 weeks gestation, we have no normative data, none, for most things.
Yeah.
We don't know what is, and what you define as, probably normative is the wrong word. What constitutes a stable infant at those gestations from, as mentioned previously, most of the therapies that we use, we have translated the science from trials that have not enrolled patients at those extremely low limits of gestation. I think, and I think that's where then when one approaches these babies, one is trying to use whatever information you have in a thoughtful way, but not necessarily having very strong opinions on that, because you can't, you just can't have those type of strong opinions. And I think, I agree everything with what Elizabeth said about the midline position. I think it is appeared because people are desperate and want something to do. Like the fetus in utero doesn't have his head in a fixed position. Doesn't. The head is moving, okay? And I'm sure there are times in which it's in a position turned, and they're not born with grade 3, 4 IVHs, So I think, what I wanted to really get is that I think that within centers, people need to understand what they do, why they're doing it, and then, not be certainly evangelical one way or the other, there are things we see on echo that we don't understand. Not everything is clear. And I think in times of lack of clarity, that's where you have to take a step back and actually try to really be thoughtful about what does this mean for this patient in this context. And I would say the same thing for skin to skin. I think it's really, really important. That we also have to be thoughtful if you do skin to skin and the baby gets worse during skin to skin. Okay, we haven't talked about that. Why is that happening? What does that mean? What's the impact to the parents if that were to happen? I'm just curious to hear from everyone as to how do you navigate that if there is a deterioration. Deteriorations can happen independent of maybe having skin to skin. Babies get pulmonary hemorrhage, for example. If something were to happen, how do we approach that? How do we navigate that? Because it may be nothing to do with skin to skin. It could just be coincidental. But those are the realities of things that can happen, and we have to have ways of managing them. So I know I've kind of been a bit wishy-washy, Souvik, from that perspective. But
that's actually a great question for Elizabeth to tackle, is because I'm pretty sure when you do that 100% of the babies, there are some babies who might get worse, as Patrick said. So maybe you can tell us, like, how would you navigate that situation? And
Absolutely.
then we can come down to some great questions that are coming up on the chat. I'll let Silke tackle those after this response.
I mean, again, there's still so much to talk about, but I will say from that perspective, again, parents as partners, families as partners is so important in this work. And we still have a ways to go as regards to really having, equal partnership as we think about these really fragile infants. But when you have a partnership and you have good communication, then you are able to talk about those potential risks, even before the practice. And so I do think, again, from large databases through Vermont Oxford, through California Perinatal Quality Care, all of our larger improvement networks, we've seen there's no increase in unplanned extubation, for example. But still, does it happen? Well, yeah. I mean, an infant can have an unplanned extubation right in front of you on a bed, let alone sort of on their parent's chest. So it may happen. So how do we anticipate that, communicate about that, and then how do we provide support and recover from it if it happens? And I think, again, when we introduced this sort of philosophy of care, it was about IVH reduction, but it became an 80-page document about neuroprotective care. And what it means is that every decision we make for this infant, we talk about survival and thrival. I know it's not a word, but I want it to be a word because it sounds better. Survival and thrival. How do they thrive? Is me doing another heel lance right now to get a glucose going to help this baby thrive? And so every decision we make in care has to be sort of in that context of both contributing to the best survival outcomes, but also contributing to the best brain development. And that's how we focus it and talk to families about it. But I do think you have to acknowledge that sometimes these things will happen, but if you've anticipated them and then provide a lot of support around recovery, and a lot of that comes from peers, families talking to each other. You did a great job. There was nothing that you did that happened to me. This is just, this is where we are. So supporting structures, building structures that support our families is so important, and certainly in the US lacking.
Great. Silke, do you want, I see that there are some great questions, so I kind of let you pose those questions to our discussants here.
Yes, I also agree what Elizabeth said. It's important really to explain to the parents what can happen. I still can remember it's many years ago, and many weeks later I could kangaroo. And at this time, they said immediately it could happen because at our time it was only possible when Lucas was already extubated, so with a CPAP. And they said, but even then, when he feels not comfortable, when I feel not comfortable, then he will go back to the incubator. And they also explained to me everything what can happen. And still it was super nervous at this time just to get him on my chest and what could happen. I'm doing something wrong. Maybe he's still so tiny. At this time it was not possible in the very early days. And so, but this is important to talk to parents and to really have this partnership. And I mean, I believe that Patrick has the same partnership also with his parents. So with this outcome, what you are presenting is I'm sure that you have it. The question is more on how early early we can provide skin to skin. And what also comes to skin care is, of course, providing mother's own milk. And there is a question here in the audience when it comes to early skin to skin. It's also proven, and this is also what Kangaroo Mother Care says, that at the end it is also not only the skin to skin, it is providing or having earlier mother's own milk. And there would be the question how you see the relationship, and maybe also Patrick, the question, do you also measure at the end how much milk the mothers finally can produce and be provided to the baby when they have not this early skin to skin? Is this something what you measure as well? And the question also from the audience, do you see here a relation? So maybe a question to both of you, maybe first Patrick and then Elizabeth.
So it's a great question. I don't know the answer. It's a really interesting question. Obviously, we very much promote breast milk in our tiny babies. We're not aggressive feeders. We feed cautiously. Our belief is the smaller you are, the preterm intestine is not designed necessarily to have milk in it. It's designed to have amniotic fluid. So we do feed slowly, which may also contribute to our low neck rates, but we're 100% breast milk. It's something I'm going to ask the question too, because that's where having centers, having data, and it gets back to the question earlier about comparing, you asked it, Silke, the different centers with high survival rates for extremely preterm babies. These are good questions to try and get that data from, because that's really, really important. So I can't answer the question. I just don't know at this point in time.
Well, we know the data exists for full-term infants going skin to skin immediately after birth. We know for older infants. And so I think, again, can we extrapolate? Can we use common sense that the same physiology is going to help, a mother who's or a birthing parent who's delivered preterm? I think so. And one thing I wanted to just say is that we, how often can we extrapolate from older gestational ages, and yet, if it's clear, like with breast milk provision, I think that we can safely do that again and not cause harm. And just wanted to bring up that there are other barriers of an infant being, too sick, and that came up in the chat as well. There's a great reference from Marvin et al., who looked at high frequency heart rate variability as a sign of infant resiliency against stress. And it turned out that in that small study, single center, which a lot of these are acknowledging, but it was the infant who had the highest acuity scores, so that the sickest, who actually benefited the most from going skin to skin. And those benefits included, duration of hospitalization, duration of time on oxygen, duration of time on mechanical ventilation, in addition to what we know, breast milk and cortisol regulation and other things that are just now we know to be true of skin to skin therapy.
I just want to convince you for any kind of data collections to really have the whole nutrition pathway also really measured, because we have here in Germany a neonatal network, and when I was involved as a patient representative, but not really had a voice when I started, so that was very common at this time. But then after a couple of years, I said, why are you not measuring at the end? Does the mother really, or was the mother able and when to provide colostrum? And if not, why not? So that you really can measure also the nutrition pathway, because many of these very tiny babies have problems at discharge and at home to really be fed, fully breastfed, or even to be provided with pumped mother's milk or with donor human milk. And that is something what you all know, that this has a huge impact. And I'm impressed you have a 0 neck rate. That's really amazing and fantastic. We have this, we have also smaller rates compared to I would say the majority of US, but it's a 0.1 is really fantastic. And what we really would like to have as patients, parent organizations, having really the whole nutrition pathway, because many of the children come home, have problems with feeding difficulties, or with growth. And this is a challenge we face then afterwards. And therefore, it's not, I always say, it's not only the classical things what need to be measured and documented and also benchmarked at the end. So it's really the nutrition pathway, because we as parents, and of course the child as well, suffer a lot from at the end not having support with breastfeeding, and that would be something what is really important for the future. And it links, of course, to the skin care. It links to the involvement of parents, because you lose your milk when you're not in the end be supported for many aspects what you need around. So maybe an input for your discussion when you have future discussion with Oxford Network, Vermont Oxford Network, and many other networks you are working with experts.
Agreed. And Silke, I'll just say, even though Patrick and I are on the pro-con here, we're actually, our centers work together. And one of the things that we're looking at as well is the development of the microbiome. And we know skin to skin helps diversify the microbiome for older babies. So can we assume that the same is true? And so that's something we're working on together.
Yeah, so this is all wonderful discussion. I know that we are slowly running out of time, and we would probably love to carry on with some of these amazing discussions, but I think we slowly have to wrap up and bring this discussion to a close. So a few things that have come out, and Silke, you can add on to that. So what I'm taking away from this is, it is important. Skin to skin is absolutely important. But there is no good data in the smallest and sickest babies. So we need to learn from the centers who are doing it. Can we learn? We can generate evidence from a lot of ways. Randomized trials is one, but is this intervention the right one for randomized trial? I'm not hearing from experts that that is the right way to go. I think what we rather need to do is learn from the centers who are doing it successfully, look at how they're doing it, what their philosophy is, approach is, the logistics is, support is. Because if I'm in a center who wants to do skin to skin care, but I do not have the nursing training support, respiratory therapy support, it'll be a disaster. And probably the outcomes will be way worse compared to centers who are not doing it. So I think we need to look at those aspects before we jump on to say that this is something that we absolutely have to do regardless of our resources. I think that's what I'm hearing. Parents as partners is key, and that is something we should be highlighting all throughout, right from the birth, even before the birth of the baby, and that will only enhance the relation between the healthcare providers, the parents, and make those discussions around deteriorations easier. That what happens when the baby does deteriorate while they are on skin to skin care, or discussions around why we chose not to do it in these babies because of these reasons, maybe because of lack of evidence or support, or a combination of thereof. So that's what I'm hearing coming out of this discussion today. Silke, Patrick, Elizabeth, anything you want to add to what I mentioned?
Yes, sure. So I really enjoyed the discussion, and it was not really a controversial discussion about no skin to skin or in the end skin to skin care. It was more when to start. I guess this is also important that we discussed at the end the moment and the safety of the babies. And this is really a key message, I guess, for everyone who is watching us and looking in our discussion. What really is important, I guess, to understand that the parents are the partners. And I know that also many parent representatives of parent organizations are joining today, and we will also watch afterwards. It is important to collaborate, maybe because when we talk, Souvik, about discussion about training and education and looking of units or hospitals who are practicing it, the question is often of how can we finance it and how can we finance such a training? I mean, one is to have enough nurses and doctors and the will to do this. The other thing is you need the training and the education. And what we can show here in Europe, but also in the worldwide, that many of our parent organizations are doing charity activities to finance trainings for healthcare professionals, even in the pandemic, digital training. So this is something where it's not a reason to say, no, I have no money, we cannot do it. please collaborate with our parent organizations. They are willing, doing charity activities just for Prematurity Day happened. So there's an opportunity if there is a will in the hospital and just we have not enough resources, that would be an opportunity. And this is what I want to convince you and also to push the things forward. Of course, the safety first, but when there is the question mark about education, training, lack of money of really doing it, when there is a will to start, that is something where I would like to give the hands and make connections to our parent groups to really be able to manage it, because that is always, there's always a way to make things possible. And I guess Elisabeth and Patrick also maybe want to have some closing words.
Well, one last thought I just wanted to share is around the idea of what we've learned in California is that bias and discrimination do exist outside our hospitals, and they don't, unfortunately, stop at the hospital doors. And what we've seen when we've tracked all of this data is that there are sometimes families and children who don't benefit to the same degree as all others. And so specifically, my colleagues at Stanford have done good work on this, that skin-to-skin care is not provided equitably to, for example, families for whom English is not their primary language in California and others. And so I just implore everyone that as we're tracking all of this data and using it, that we're also ensuring that every family and infant is really having their care optimized and benefiting from this important practice.
Yeah,
very important.
Let me echo kind of what Elizabeth said. Actually, one of our researchers is actually looking at the same question in, breastfeeding. And the exact same patterns are being seen. The vulnerable minorities, people with language kind of barriers. And there are also, cultural things that, in the United States, it's not normal for people to breastfeed in public. And a lot of people with language difficulties have interpreted that, well, then they should not be providing breast milk for that reason, which I had not even thought about. But that is a US thing compared to, say, countries in Europe. It's very, very different. I think my last comment is, obviously we are going to explore this and look at how we can integrate this within our program. I do think it's the right thing. I think there may be symbiosis between our precision-based care with this. But I think the devil is in the detail, and data is important. And I think one of the things that I am interested in here is, the use of predictive analytics and kind of more comprehensive ways to monitor patients. So we have SickBay, which is a comprehensive kind of data stream, giant brain that takes data in from every single monitor, every single piece of equipment attached to the baby. And I think that would be really, really interesting to actually look at when babies go on skin to skin, to have this real-time, continuous, multimodal data and actually look at that. That will certainly be a great way to answer the question around the physiologic piece, because it removes the biases of people choosing a blood pressure or choosing a heart rate or choosing a saturation to record. This is the real data, and I think that would be really, really powerful. So I've just put that on a list of something that we should do when we implement this. So
thank you, Patrick. This is wonderful, and thank you everyone for your inputs into this extremely important topic, especially on the occasion of the World Prematurity Day. So I'd like to bring back Fabiana to the discussion and maybe have her give us some closing comments.
Wow, I want to thank all of you for participating in this great discussion today. Always learned so much from different experts, and was really eye-opener to see what other centers are doing outside Canada and engage this amazing community around the world. So I'm very grateful to all of you. And this is certainly not the end of the conversation. I think that is the beginning of a conversation, because I realize how much work still needs to be done for our extreme preterm babies. But I'm very grateful today to have you all here with us. And Souvik, thank you so much for giving us the idea to have these discussions with scientists and experts from around the world to really make this a very democratic conversation where we are online from many parts of the world participating in this discussion, teaching other centers and learning from other centers. So I'm very grateful for this opportunity to host this Scientific Preemie Chat. It's our first one, certainly not the last. I think we have many more themes and topics to discuss next year. And please feel free to send us if you're watching us live, to send your suggestion, which other topics should we be discussing with these scientists and experts. So thank you all. It is being an incredible month of raising awareness on Skin to Skin with World Prematurity Day. We've seen sites around the world and parent organizations around the world really raising awareness on preterm birth, and especially in the topic of skin to skin. So Silke, thank you for creating this amazing day for all of us to raise awareness and really show all the scientists and clinicians the impact of preterm birth in our personal lives, raising a child with who were born extremely preterm or late preterm, and the impact it has in our lives and in our baby's life. So I'm very grateful to each and every one of you here today.
Thank you.
Thank you.
And to all
Thank
of
you so much.
Watching us live today from 53 different countries, thank you for joining us on this very special first edition of the Scientific Preemie Chats. If you missed part of the debate today, please head over to our YouTube channel or website, canadianpreemies.org, to see this episode and all past editions of our weekly Preemie Chats. We have almost 300 sessions on a variety of topics recorded there. And I want to thank again EFCNI and all the other organizations who collaborate with today's sessions: the Canadian Preterm Birth Network, the Canadian Neonatal Network, EPIC, Canadian Neonatal Follow-Up Network, Family Integrated Care, Canadian Association of Neonatal Nurses, and GLANS. And please consider how you can support CPBF and its mission to empower families of premature babies in every step of their journey. Together, we can create a brighter future for all preemies and their families. And we have another session live this Friday, 1 p.m. Eastern Time. Stay well.